Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.
You're listening to Healthcare Matters, the podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. With us is Dr. Robert Popovian in Washington, D.C. He's a pharmacist, an economist, and the Chief Science Policy Officer at the Global Healthy Living Foundation.
And joining me is my good friend Ben Blanc, dialing in from Indianapolis, Indiana, who's our manager of programs and special project at Global Healthy Living Foundation. Ben is doing double duty today. He is going to be joining me as my co-host as we start our season 5, episode 1. He's been a great producer and he will be the co-host. You may catch a hint of his sophistication in the air, or some type of a je ne sais quoi, as they say, as Ben is originally from France. So, Ben, this year, a lot going on in Europe. We have the Euros in Germany. We have also a big year in France, the Olympic Games this summer. So are you going to be visiting your homeland?
Well, let me think, Robert. Paying double for flights, Paris will be packed, inflated prices for everything. Yeah, I think I'll stay home and watch the games on TV.
That's probably a safe bet and start watching it on TV. Speaking of global events like Olympic, health and safety, especially in these days, are top importance, much like topics we always tackle here on Healthcare Matters podcast. And for today's episode, we have a very special guest, Vibhu Tewary, who is a researcher, and he's the project director at the IQVIA Institute for Human Data Sciences. We've collaborated on multiple occasions on research initiatives and papers. So I welcome Vibhu on our podcast, episode 1, season 5. Vibhu, welcome. I want you to give some background for our audience about what you do at IQVIA and also your academic background. Take it away.
Thank you, Robert. It's a pleasure to be here. Robert, as you mentioned, I'm a project director at the IQVIA Institute. I've been working with the IQVIA Institute for a couple of years. The IQVIA Institute is a small part of the broader IQVIA organization with the objective of using the data assets that IQVIA has to contribute to public health discussions, public policy discussions, with a view to have an impact for patients and other stakeholders in the overall health system. Prior to being with the IQVIA Institute, I was in the broader IQVIA as part of the consulting team. Before that, I went to Duke University for my MBA with a focus on healthcare management. However, public health, public policy has always been close to my heart. Prior to any of this, I used to work in India at a policy think tank looking at rural education, rural healthcare. So all of these topics are really, really interesting, really, really close to my heart, and I'm looking forward to diving into them. So really happy and honored to be here and looking forward to the conversation.
Well, welcome aboard, Vibhu. And Robert, you know how it goes. We always start the episode with a number, and today that number is 13. $13 to be exact. Can you tell us the significance there? And yes, it relates to today's episode.
So Vibhu and I worked on the study that we're going to discuss today on the podcast, which basically demonstrated that a $13 increase in pharmacy reimbursement for adult flu vaccination was associated with nearly a 6 percentage point surge in state vaccination rate for Medicaid fee-for-service covered adults. And this is important because that's the crux of what we found. And this is what we're going to be discussing today on the episode.
Well, I'm sure you'll be telling us all about this report that you two co-authored. But before we get into it, let's start this episode with a little bit of background. In 2023, GHLF and IQVIA Institute for Human Data Science released a paper that evaluated where adult patients in the US received their immunizations before and after the pandemic. Vibhu, I'm turning to you with my first question. What are the main findings of that 2023 paper? And by the way, I read the report and it seems like the number 90% really stands out.
Yeah, thanks, Ben. So I think as you mentioned, the objective of that research was we wanted to understand where are adults in the US getting their vaccine. Is it at pharmacies? Is it at non-pharmacy settings like medical centers? And to do this, we looked at the IQVIA prescription and medical claims data. We can tag that on the basis of whether the claim came from a pharmacy setting or not. We looked at this data starting from 2018. We went up all the way to middle of 2022. And what we find is that overall, across all vaccines that we looked at for adults, a large majority of the administration took place at pharmacies. In particular, during the pandemic, so 2020, 2021, we saw a steep increase in vaccine administration at pharmacies. This is driven by a number of factors. If you look at the COVID vaccine, the 90% number that you mentioned comes into play. So more than 90% of COVID-19 vaccinations for adults were provided through pharmacies in both 2021 and 2022, if you exclude the temporary and government public health side. Now, this trend holds even if you analyze the data by race, gender, income level, it's still all above 90%. This isn't just true for COVID-19 vaccines. Even your shingles vaccine sees a similar trend, with a large majority of the administration taking place at pharmacies across all of the years that we looked at. The flu vaccine is interesting. Around 60% of the vaccination during flu season takes place at pharmacies. Another interesting trend that we noted was between 2018 and 2020, there are increases in flu vaccine uptake, but all of those increases pretty much are happening at the pharmacy level. The flu vaccine administration at the non-pharmacy level is pretty much remaining stable. I think all of these findings, they highlight the importance of pharmacies, the role they're playing in adult vaccination, and really shed a light on the crucial importance of these pharmacists.
Gotcha. Well, thanks for the overview, Vibhu. Robert, do you have anything to add? And actually, considering these findings, could you share your thoughts on the policy implications and barriers that are relevant to the findings?
Yeah, absolutely. And barriers are significant at some states, not as significant in other states. As many of our audience knows, practice of medicine or practice of pharmacy is governed by state law. It's not governed by federal law. And when we looked at the data that we published with IQVIA at GHLF, we quickly realized that what we need to do is harmonize, expand, enhance state laws to allow pharmacists to immunize more, especially for adult patients. And the reason being is that that's where patients prefer to go to. And that's where the vaccination is happening. But, currently that environment is a complete mess. As I said, every state is different. There are multiple states that don't allow all the vaccines to be administered by the pharmacist for adult patients, which is a sad truth, and that we need to do a better job of fixing those. But the reality is that patients want to go to a pharmacy. They're more accessible. They're more relevant, and in low-income communities, especially compared to physician offices where patients can go after hours, and especially for patients who are working hourly jobs that they cannot take off from those jobs in the middle of the day to visit a physician. The pharmacies are open after hours. And frankly, there's evidence that economically it's less expensive to immunize at a pharmacy than it is at a physician's office. So all of these things are policy implications that policymakers need to take into consideration, especially on the state level, as I said, because that's who governs practice of pharmacy and allows for immunization to take place by pharmacists at the pharmacy.
Very clear. Well, now that we have all this background, let's talk about our most recent co-authored report, which again is a joint effort between IQVIA Institute for Human Data Science and GHLF. The report just came out in February, and I'll sum it up for our audience before we dive in. Simply put, the paper found a direct link between pharmacy reimbursement and flu vaccination rates among Medicaid-covered adults. So, of course, understanding the motivation behind a study is crucial. Robert, could you share what drove us to undertake this particular piece of research?
So it was interesting because the previous research that was done, and Vibhu and I had a long discussion about this, was mostly done on surveys, right, of physicians or pharmacists. And basically these studies went and asked physicians, like, if you get paid more, are you going to vaccinate more? And obviously physicians would say yes, but there was no empirical data to really support from a research perspective if that's true, that whether or not high reimbursement rates drives uptake of flu or any type of adult vaccination. There's some literature that was published previously on pediatrics where better reimbursement rates on the pediatric side does improve pediatric vaccination uptake. So what we wanted to do is duplicate that study on the adult space and really to get away from the survey stuff that was done either by other organizations that have published in the reports and really get into solid data to support whether or not reimbursement increase will impact uptake of flu vaccines. And we chose the Medicaid population primarily because, the Medicaid population is underserved. We know that it's overrepresented by minorities. So if you're interested in, equity and inclusion, you want to improve care in a Medicaid population because there's a lot more racial and ethnic minorities in the Medicaid patients. And then we chose flu because flu is something that everybody is, recommended to get. It's not one of those vaccines that's age specific. Everybody should get a flu vaccine. And so those are the impetus that we really talked about and motivated us to get into this study and try to see if there is a correlation.
All right, now that we know why this paper came to be, Vibhu, could you walk us through the data and methodology that were employed in this report?
Yeah, thanks, Ben. So basically, to understand this relationship, you need two broad sets of data points. One is, what is the vaccine uptake for the Medicaid population? And then the other piece of it is, what are the reimbursement rates for that same population? We again looked at IQVIA prescription and medical claims data, particularly for the Medicaid fee-for-service population. And we're able to mark out, in terms of the entire population that's there in the IQVIA data, how many of them are actually getting their flu vaccine. We looked at this for the 2022-2023 flu season. That, at a state level, gives us a percentage. So for each state, what percentage of their Medicaid fee-for-service adult population is actually getting the flu vaccine. Then we looked at what is the reimbursement rate in each of these states from these same set of patients. And by reimbursement rate, we mean how much was reimbursed for the vaccine supply. If there's additional reimbursement for vaccine administration, how much was reimbursed. And from that, we subtract out cost of the vaccine itself. We did this both for pharmacies as well as office-based physicians. So for each state, we end up with a number. Now that we have both of these sets of numbers, we want to compare the two. To be able to do that, we set up a multiple regression model where we look at our dependent variable, which is the vaccine uptake rate, and have the reimbursement rate as one of our independent variables, along with other variables at a state level. So we looked at state per capita income, state education level, other factors that might be impacting within the Medicaid population, how many people are actually getting the flu vaccine. Looking at this data, I think as we started off right at the start, what we find is a $13 increase in the reimbursement rate would lead to a 6 percentage point increase in the overall flu vaccination in this specific population. I think it's interesting also just to highlight, why did we choose 13? 13 is the difference between the average reimbursement rate, which is around $12 or so, based on our calculation across states, and the highest reimbursement rate, which is 25 or so. So that's why we were looking at that $13 number. Again, I think there's also a lot of other factors that come into play in terms of what raises the vaccination rate. But this research clearly with data highlights that there is an important link here between reimbursement for pharmacies and for the adult vaccination uptake. So I think it again highlights that important role that pharmacies are playing.
Yeah, thanks for breaking down all that information for us. And I know the findings are compelling. So Vibhu, say you had to prep a slide presenting the key findings of this report. What would your bullet points be?
I think the top line message here is, if you increase reimbursement rates for Medicaid population, you will see an increase in the overall vaccine uptake. That's what the research is showing. Specifically, if you increase it by $13, the research shows that it would increase by 6 percentage points. Those are the main takeaways. If I had to add another bullet point, we looked at this by gender, by race, and in general, the results hold irrespective of gender, irrespective of race. So this is consistent across the board.
Yeah, that's very clear. Now, every study has implications that extend beyond the data, right? So, Robert, from your perspective, what are the policy implications of these findings?
Well, the policy implications are that if you increase the reimbursement rate, you're going to get better uptake in Medicaid patient population for regards to specifically on flu vaccine, but my belief is probably other vaccines. And this is important. As I was mentioning earlier on, Medicaid populations, minorities, racial and ethnic minorities are overrepresented in those patients. So if you're serious as a society to, reduce health disparities and improve equity and access and all those other things, then you need to be serious about improving reimbursement. And one other thing I want to give some observation on is that from a policy perspective, Medicare is a good barometer right? Medicare reimbursement is much higher than Medicaid reimbursement on average across all the states. And one of the policies that we discuss and we recommend is that perhaps the Medicaid reimbursement should equal Medicare reimbursement. There's no reason why patients who are poor and indigent and are, again, overrepresented by racial and ethnic minorities should get lower reimbursement for their vaccines at the pharmacy, which clearly will demonstrate a better uptake than Medicare patients are seniors. So, yeah, that's the main policy issue. But, this is another area of focus of trying to remove a barrier and improve access uptake, especially in a very vulnerable patient population, underserved patient population.
Yeah, that's very insightful. Thanks, Robert. Are there any other areas or topics that can potentially be evaluated for future research? Who wants to go first? Vibhu, should we start with you?
I think there's quite a bit of research still to be understood here to ensure that adult vaccines are reaching the right populations. I mean, in my head, there's two broad categories of research. One is to understand the role of the pharmacist and any challenges and blockages there. That can be in terms of, do they have the right data to be able to make decisions for specific patients? And even for our current research, I would be curious to see, as states change their reimbursement rates, what is the impact that they're having? So continuing to focus on that. Are they appropriately supplied with the vaccines? And then the other side is understanding other factors that impact adult vaccination. So what is happening with the patient's side? Are they appropriately informed regarding the importance of these vaccines and where they can get it? Is it reaching vulnerable populations, and can that be ensured for health equity? So there's two broad sets of discussions here, all of which I think there is data out there that can help shed light on it and needs to be looked at in more detail.
And what about you, Robert? I'm sure you also have an opinion on this.
Yeah, I mean, we are in midst of doing a survey, actually, of Global Healthy Living Foundation patients. All of them have chronic disease. Almost all of them are immunocompromised. And trying to see what are the blockage points for them regarding vaccines. Are they getting denied, whether it's at the physician's office or a pharmacy, with regards to having access to a vaccine? And then what are the reasons for that denial? Is it because out-of-pocket costs, which shouldn't be, right? Because of Affordable Care Act, the Inflation Reduction Act should have taken all of those things away, and patients should not have any out-of-pocket costs. But we still see some instances where patients are being charged upfront for the vaccine, and the way that the benefit design is set up, and then they have to go get reimbursed, which is, as you know well, and throughout our podcast, we talk about any kind of out-of-pocket cost that is significant. Patients are not going to take the medicine or get the vaccine, and are going to walk out of that institution or that pharmacy without their therapy. So that's one of the areas that we're going to focus on. And then another thing Vibhu and I've talked about is this whole shared clinical decision-making and the impact it's had. It's a policy position that CDC has taken over the years for adult vaccines especially. And what is the impact of that policy on vaccine uptake in adults? Is it good, bad, indifferent? We're going to hopefully have an opportunity to look at that in the next 12 months or so.
Yeah, thanks, Robert. And a heads up to our audience, we'll be dropping all the links to the papers we've been talking about in the show notes, so make sure to check them out. And as we wrap up today's discussion, do either of you have any final thoughts about the joint research conducted?
Let me say that at GHLF, I'm personally thankful with Vibhu for his partnership. GHLF and IQVIA Human Data Sciences organization have done a lot of good work for patients. And that's the thing that I have come to realize partnering with Vibhu is that both organizations are focused on patient and patient access. That's the most important thing. If we can do research, not for the sake of doing research, but meaningful research that's going to improve that access point, then we should be partnering up and working together. And we're open to further collaboration between the two organizations and even beyond, bringing other partners.
I'll just echo that. I think both the sets of research we've discussed here have been really, really intellectually interesting questions, but they have a direct impact on the patient. And it's honestly been a pleasure to work with the GHLF team on these projects and on these pieces of research and see the impact that they can make. Some of the research that Robert is mentioning, I think we're very excited to continue this partnership. And if there are other stakeholders that are relevant and interested, I think we're always open for other partnerships moving forward as well.
Thank you both. that's all we've got for today. So thanks again so much, Vibhu, for joining us. And Robert, as always, you have the last word. So what sticks with you from today's episode?
Well, that you're a pretty good co-host. How's that, Ben? But, what sticks with me is that the value of research and data is sometimes underappreciated. And we sometimes talk about policy issues from an emotional standpoint, or, we want to bring up examples. But when you have data, then you can really drive down policy change in the United States. And that's very important. And I also want to thank Vibhu for joining our podcast, season 5, episode 1. So you're going to be front and center, Vibhu. And we look forward to having you in other podcasts in the near future.
Thank you, Robert. It's been a pleasure.
Well, thanks for breaking that down for us, Robert. I think that was some very valuable information for our listeners. And speaking of our listeners, don't forget to subscribe to our podcast on Apple, Spotify, or wherever you might be listening, so you never miss an episode. And if you have a second, help spread the word by rating our podcast, writing a positive review, and sharing with your family and friends. It will help more people like you find us.
And if you have any questions, thoughts, suggestions, as always, you can email us at podcast@ghlf.org.
And before you go, make sure you take a listen to some of our other great podcasts on the GHLF Podcast Network. You can find all of GHLF's podcasts at ghlf.org/listen. He's Dr. Robert Popovian.
And he's Ben Blanc, and you will not find him in Paris this summer. We'll see you all next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.